All right, good morning, everyone. I actually was one of the inaugural fellows to this conference. My picture was up there, and I've been going every year. Last year, I was a billion weeks pregnant, at least it felt like it. I do have three pieces of advice about IBD in general. The first one is keep up with the data. As you all probably figure out by now, it changes really rapidly. So it's really important to keep up with it. Make sure you're seeing patients. I don't care if your many specialty is whatever in GI. Just make sure you're seeing your own patients in IBD. Like, you know, I do liver, but I still see IBD patients. Actually, I try to do it almost like every week if I can, because they're always very interesting. They always provoke a lot of thinking. So don't forget, you're going to graduate and you have all this IBD knowledge. Do not lose it. Just keep up with it. Like, I don't know, a few weeks ago, I paid and went to this IBD conference so I can keep up with the data. The second one is it's a team sport. So make sure you know your colorectal surgeons, like Dr. Murphy comes to a lot of, she comes and see a lot of my patients that I scope because I have questions for her. Does this patient need surgery or not? You know, they're always happy to come, happy to see, happy to get consulted, even if they have no, surgical plan in the future or near future. It's good to know your colorectal and then have a mentor. Dr. Patel says I'm his, what is it, PGY 7 or 8? 8, yes. So I text him all the time, and sometimes he doesn't respond. So I say, question mark, question mark, question mark, hello, you still here? Eventually he responds. But I think he gets annoyed. Anyways, all right, so we're going to talk about medical therapy. So these are my learning objectives. I'm going to try the best I can to go through the most important things, the most important trials. Obviously, I can't do all of them. So that's where you come in by reading, learning, seeing your patients, and asking questions. The question is, why do we treat? What's the goal here, right? So, we want a lot from those medications, right? We want the patient to feel better, right? Ideally, we want them to feel, normal, right? We want the labs to look good. We want the albumin to be normal. We want them not to have anemia. We want them, the CRP to be normal. We want to have, no evidence of luminal inflammation. But finally, we do want to see that the intestinal mucosa have healed. There's no visible evidence of ongoing inflammation. And then the last metric for us should be when we're targeting this therapy is to see how effective are those medications that we are using. And then obviously, mucosal healing for now is the typical thing that we want to accomplish, as well as clinical remission. And then we can also strive at the end that pathologically that the patient would also, under the pathology, that it would look better. So this is kind of like what are our goals, and that's kind of was highlighted in the STRIDE trial. So whenever we pick a therapy, whenever we pick a medication for a particular patient, we do want to talk about, what's the mechanism of action? How fast is it going to work? And then is special consideration, is the patient pregnant? Are they old? Have they tried therapies before and they lost response? What's the immunogenicity to this drug? Am I going to monitor this drug? What does that mean? There's a lot of controversy about that. What the route of the drug, how often they have to be. Is that someone that can get IV infusions? Can they inject themselves? Can I just give them a pill? And then how safe is the drug, right? All right. So whenever we don't control the disease, whether it's UC or Crohn's, the patients will likely flare. They get hospitalized. And I do want you to know that 25% of patients that are not well treated will get hospitalized for severe IBD or complications. And also patients, if they're not well treated, they will likely get colorectal cancer. 30% of UC patients would require a colectomy. 60% of Crohn's disease patients will require some sort of a resection. And then, of course, they have an increased risk for DVT, MI, stroke, and then mortality, especially during flares. So it's not a joke, right? You do want to control these patients. All right, so this is the majority of the drugs there, and what are they used for, which disease, and can you use it for induction? Can you use them for maintenance? Obviously, at the top there is steroids. We can do induction, but probably shouldn't put a patient on that for like maintenance, right? And then a lot of drugs are coming on the market, so do your best that you can to keep up with them and see like, is the patient's insurance going to cover it? All right, so from safety-wise, obviously, this is the kind of like the triangle, like, you don't want to give your patient steroids, right? And then Vedo, obviously, is probably the most specific, for targeting the bowel, so not a lot of side effects there. So we're going to start out by talking about anti-TNF agents. The most popular one, the most one we use is infliximab. So infliximab, if you want to think about it, is like an artificial antibody. So it was originally developed in mice, so as like a mouse antibody. And because humans have this immune reaction to mouse protein, the mouse common domains are replaced by a similar human antibody domains. And so it's called a monoclonal antibody. And then we combine the mouse and the human antibody together, so it's becoming a trimetric monoclonal antibody. And there's other drugs in that class, so adalimumab is there, and then the other ones, we don't get to use them as much, but the two popular ones, infliximab and adalimumab. When we think about dosing, we think about, well, how much, is it 5 mg per kg? You can also, for infliximab, you do 10 mg per kg as well. And then we do the induction, and then you do the maintenance. And the same thing you for Humira or adalimumab, and then you have the other 2 drugs as well. So the SONIC trial basically was a landmark trial for anti-TNF. And we used that for moderate to severe Crohn disease patients. And it was tested on patients who were naive to immunomodulators and biologic and had an average disease of less than 2 years. And it was randomized to placebo, whether it's infliximab alone or infliximab with azathioprine. And the reason why it was kind of like a highlight is we used a steroid-free clinical remission as kind of like one of the goals at week 26, as you can see here, that patients with infliximab and azathioprine seemed to have a higher percentage of having steroid-free clinical remissions in comparison to azathioprine and in comparison to infliximab alone. Well, what about things like mucosal healing? Same thing, we found that when you have combination therapy from infliximab and azathioprine, those patients tend to have higher percentage of the patients had chances of having mucosal healing at 26 weeks in comparison to azathioprine alone or infliximab alone. All right, well, what is some safety consideration for infliximab? Some of the adverse effects of infliximab, or I guess anti-TNF in this particular slide, they're like some sort of injection reaction or fusion reaction, maybe neutropenia. You want to monitor their CBC. Is there sort of they're more likely to get infected. You do not want to use them in patients with demyelinating disease like MS, heart failure, any sort of ongoing malignancy, particularly skin cancer and lymphoma, and then patients who maybe have some sort of other autoimmune disorders like AIH that's not controlled. And then contraindication, if they have an active infection, probably not a good idea. If they have latent TB, if they have, again, like things like MS, any demyelinating disease, uncontrolled, particularly heart failure, ongoing cancer, they're getting treatment, and of course untreated hepatitis B, because that could cause a flare and could be pretty actually deadly. So, well, okay, let's talk about this lymphoma thing, because a lot of patients will read that online and ask you, well, what's my risk of getting lymphoma, please? So Sometimes we print this kind of chart and tell patients when you have all these like percentages, what does that like even mean? So actually, if you have untreated IBD, you have a risk of having lymphoma. If you use azathioprine or 6-MP, there's a risk for you to have lymphoma. And then we don't really know the risk for methotrexate. The risk for infliximab or Remicade or, like Humira, the list is actually less than 0.04%. And then we don't know the risk for steroids. And then the risk for dual therapy when you use immunomodulator plus anti-TNF is about 0.04. So when you have, when you tell them show them a picture of all the, what does 10,000 people or 100,000 patients look like, and your percentage is like this tiny, tiny red dot up there, it makes them kind of comprehend that it's not as huge of a risk as they might have thought, because in fact, them having untreated IBD also increases the risk for cancer as well as lymphoma. So give them that grasp idea of I'm not giving you lymphoma in a pill, okay? Your risk is very small. All right, so that's kind of the anti-TNF in a nutshell. Let's talk about the next class therapy was anti-integrin. If you, let's see here, is this, yeah. So if you look here, this is Entyvio, or Vito, and you can see here it's kind of trying to prevent this molecule here from the T lymphocytes, which kind of causes inflammation, from kind of attaching up here. And that's kind of the big picture when I explain to patients is how the Entyvio kind of works. So it kind of blocks that interaction between these two molecules. So when it does that, it prevents the lymphocytes to migrate into the colonic mucosa. So it kind of prevents the exit ramp to go into the colon. And then we know that it's effective for both UC and Crohn's, and the dose is 300 mg at week 0, 2, 6, and then they can have it every 8 weeks. So actually, Vito is pretty well tolerated for a lot of my patients. Has a very good, it's gut selective, it has very good favorable safety profile. There was this big thing about PML, but it actually does not, one of the other drugs in that class, but it doesn't seem to have any issue with Vito, especially with this Gemini trial. There's low risk for infections, and it's limited usually to non-serious URI symptoms, and it has no specific malignancy risks identified. The big new kid on the block is a sub-Q Vito for both UC and Crohn's disease. So in the visible 1 dry, there's two of them. There's visible 1 and visible 2, one for UC and one for Crohn's. For UC, they found that the sub-Q is as effective for maintenance in patients with moderate to severe disease after they get induced with the IV drug. And it has similar safety, similar tolerability as the IV version. And then for the Crohn's disease, they found the sub-Q was also as effective and safe in maintenance patients with Crohn's disease after they get 2 infusions of the IV Vito induction. So kind of helps, the patients, give them that freedom that they don't have to get this IV infusion. They just had to get it, first 1 or 2 doses, but otherwise they can give it sub-Q. So it makes it even more easy to use for patients as well. All right, let's talk about IL-2 and IL-3 drugs. So uskizumab is right there, and you can see kind of prevents, that kind of interaction between IL-2 and IL-3 on the PD-1 and the TFH cells there. So uskizumab, as we know, it helps. It's been approved for the induction and maintenance for both UC and maintenance of remission, both UC and Crohn's. These are the doses here, and for maintenance, it's a sub-Q injection. It could be every 8 weeks. Some of the adverse reactions there, some infections have been reported, especially respiratory, injection of site reactions, very low risk for non-melanoma skin cancers as well. All right, moving on to anti-IL-23, and the big big person on the block, I guess you could say, is risconuzumab or Skyrizi. So it's selective IL-23. It's very selective. It's been approved for Crohn's disease, and these are the doses there. Again, for adverse reaction, again, few because it's selective. You can have some mild or possible LFTs abnormality, and it's recommended that you monitor the LFTs at weeks 12 after you start the drug, and it can have some slight increase risk for infection. And then mercuzumab is next on, was approved for ulcerative colitis, and that was highlighted in these two trials. So they monitor the patients at 12 weeks and then at 40 weeks, and you could see that in terms of clinical remission, it was favorable. A clinical response, it was doing really well. Endoscopic remission, even histological endoscopic mucosal improvement, it was also doing better. And then they extended the trial. Well, what about at 40 weeks? It still have been maintaining that superiority in terms of, and when compare it to placebo as well. All right, let's talk about small molecule therapies. So the first one is the JAK inhibitors. Again, when we say small molecule therapy, remember those are not a biologic. And when you think about the JAK inhibitor as a family, it's a family of intracellular tyrosine kinases. So that's like the JAK1, the JAK2, the JAK3, and the tyrosine kinase 2. So basically what it does is kind of interferes in that pathway there of the JAK inhibitors. And unfortunately, it has like a lot of multiple processes, including like immune and inflammatory responses. So whenever we talk about TOFA in particular, it's an oral therapy. It does kind of inhibits that pathway of the JAK inhibitors, and that was demonstrated in OCTAVE 1 and 2 trials. But one of the biggest things that you have to watch out for those patients is, do they have the risk of venous thrombosis, so DVT? So if the patients have like risk factors for having DVT or haven't had them in the past, that should make you think about it. Some zoster reactivation, so make sure your patients have the zoster vaccine. Any sort of EBV-related lymphoproliferative disorder can be an issue, and then the issue of hyperlipidemia as well. Another, this one, OPA or Rinvoq is the more selective JAK1 inhibitor, and if you kind of starting to get the idea, the more selective the drug is, the more easier it is tolerated in terms of safety as well. It's been approved actually for both induction and maintenance for both UC and Crohn's disease. And the doses here are a little bit different in terms of the timing of how many weeks for both UC and Crohn's disease. Some of the adverse effects that you have to be kind of monitored for possible thrombus, however, it was not really reported in clinical trial. Hyperlipidemia, again, you want to vaccinate those patients against shingles, infection, cytopenias, and some LFTs abnormality as well. But overall, it seems to be well tolerated. All right. So what is the new like S1P modulators? And we think about those are like, they're like blocking like the entrance RAM. And what does that mean? Is that basically mean when your lymphocytes are kind of like migrating from that S1P like concentration into the lymphatic tissue, it kind of like blocks it there and prevents that signaling from happening. So the biggest one is the ozanimod. So that was approved for both induction and maintenance in UC. It's considered a first-line option. It's basically binds with high affinity to the S1P receptor, and it blocks that capacity of the lymphocytes to go into the lymph nodes and the peripheral blood tissue, so it prevents the inflammatory response. And it's like a titration kind of dosing with how you start from day 1 to 4, and then you move on to days 5 to 7, and kind of like you maintain the patients on it. And then the other drug in the same class is estramide. Again, esteramide. It's approved for moderate to severe UC. It works on the S1P1, S1P4, and S1P5. It's an oral pill. It's also a first-line therapy. It can work on moderate inflammation. It can even work on proctitis. Some safety concerns, again, kind of theme here for that group is cardiac issues, some vascular reactivation, and even some macular edema. It is not safe during pregnancy and breastfeeding. So as a group, adverse reaction is bradycardia, so those patients will need some sort of an EKG before you start them to make sure there's not sort of already underlying arrhythmia. Is there some sort of orthostatic hypotension? Hypertension could be an issue, hepatotoxicity, lymphopenia is an infection, and then obviously any sort of concern for PLM, posterior lymphoencephalopathy syndrome. So whenever you thinking about putting one of those patients on, remember to put an EKG. Are you concerned about, is there some sort of an AV block? Is there sort of a sinus, sick sinus syndrome going on? Is the heart rate already low? Documentation of some of vaccination for varicella zoster. An eye exam should be documented, and then a skin exam for estranamide. So the tough part is, like, you have all this knowledge about all these drugs, and then you have this patient in front of you, and you're thinking to yourself, well, how do I pick the right drug? There's rarely like one right answer, right? And that's why it's the IBD, what makes it challenging is an art, right? It requires you a lot of thinking and thinking about a lot of different things that you have to think about. So you want to talk, like I said in the beginning, I want to talk about, well, what's the mechanism of action that I want to target here? How safe is this drug in the patient that I have in front of me? This patient's older, they want to get pregnant at some point. Their disease is very mild versus extensive. And then obviously, have they had surgeries in the past? Do they have any extraintestinal manifestation that I also need to address, hopefully with one drug? So these are all kind of things you want to address about. And a template at BAMC that Dr. Patel developed had a lot of these things in the HPI to kind of prompt you to think about all these things, like, are they anemic? Do they have skin manifestation? Do they have joint manifestations? So that kind of builds all this knowledge for you to be able to pick the right drug. So whenever we talk about how rapid is the therapy going to take potentially weeks to months? Do I need to bridge the patient to keep their symptoms under control? And then there's some drugs, work, differently than other, like anti-TNF agents have this rapid onset, maybe within days. Veto can be faster in like patients who are naive, anti-TNF naive. Maybe some drugs will take longer. Some will take, like Topa, have a very rapid onset. Ozanimide have also a rapid onset. So it's really important to kind of think about how fast do I need this drug to work? How sick is my patient? And of course, safety, right? Like I talked about, like infliximab has greater risk of serious infections, malignancy, not like super high in compared to like not having untreated IBD, but maybe when you compare it with other drugs. Like if your patient, you're concerned about their risk of malignancy, maybe Veto will be a better pick, or Rinvoq. So my patient, do I have cardiac concern? Like this patient might go, their heart rate is already like 45. Maybe ozanimide would not be a good one. So these are the kind of things you have to think about whenever you're picking your drug. And that's what fellowship is for, right? And that's why it's really important to keep seeing those patients, because you learn a lot about picking drugs when you kind of have those like practice with patients as you see them. There's something called comparative effectiveness data, and I think I really like those data because it helps me compare drugs and see which ones, like, is there any head-to-head trials? Like, there's a head-to-head trial with Veto versus adalimumab in patients with a moderate to severe UC, and we see that, which one won or did better overall versus in patients who had no prior anti-TNF therapy versus patients that had prior TNF therapy, with the understanding that there are some limitations to all the study. Like, for example, the study, there was no differences in between groups that if they've been on steroids or immunomodulators. There was no dose escalation permitted. So maybe if they had permitted some escalation of doses, maybe the effects would have been different. Also, they didn't check any drug levels as well. So kind of have to like whenever you read these data, you have to kind of like see, well, what was the limitation of the study and how does that relate to my patient? Another kind of trial that they did in bio-naive Crohn's disease patients, they didn't really find significant differences between adalimumab and icuzumab as well. So they compared them for primary endpoints like clinical remission, and then they did another, like a major secondary endpoints. There was a steroid-free clinical trial at week 52. They didn't feel like there was that much difference there. In the sequence trial, they compared Skyrizi and icuzumab head-to-head, and they ranked them based on, and looked at so many different criteria, like, clinical endoscopic response at week 40, at week 24, at week 48. How about steroid-free endoscopic remission? And they compared and you can see, how well each drug does. So whenever you're seeing a patient, you have a better idea of, maybe I should reach for the, Skyrizi first, depending on your patients. All right, and then this last one I was going to go over is this VIVID-1 phase 3 trial. They had a randomized, double-blinded, double-dummy active, control trial where they basically found that Miro was not inferior to UST for clinical remission because this freaking long names. We know that Miri had numerically greater rates of secondary endpoints, but it was not clinically significant. So you have to kind of think about that. Is the data that I'm seeing, is it clinically significant? Should I take those in account when I'm picking a drug for my patients? So these are, big kind of clinical trials where they kind of compare medications, drug. These don't happen as often as we would like, because obviously you can see why drug companies wouldn't want to compare the drug against another drug. But certainly whenever we get them, we want to discuss the data and think about it and how it relates to our patients. One of the biggest groups I want to talk to you about is the post-operative Crohn's disease patients. So after some sort of intestinal resection, it's important to talk about, prophylactic treatment with the patient and kind of, and talk about whether I want to treat this patient or versus I want to just kind of endoscopically monitor with the understanding of what is the risk factors for, recurrence. Do they have multiple resection? Are they active smokers? Do they have really hard disease like fistulizing and penetrating disease? And we know that infliximab is a really good first line for post-op patients. We also have found out that adalimumab is also a good option. We still have not limited data on newer biologic, but I certainly have seen it used as well. Big questions we get asked a lot in IBD is fertility and pregnancy. Please do remember and understand that having untreated IBD is probably the biggest risk factor for infertility and having pregnancy complications. Your patients need to be in remission for at least 3 to 6 months prior to conception. And active disease impairs fertility because of the inflammation in the pelvis, the poor nutrition, maybe decreased libido, just the pain they might have with intercourse and depression. And then, as we know, there's IBD medication itself does not impact fertility. So this is a table just kind of summarizing which drugs to continue, which drugs to kind of be worried about, and which drugs to contraindicated, like methotrexate, tofa. And then some drugs, a lot of it sometimes, honestly, we don't really know what to do with because we don't really have the data. As you can imagine, doing, clinical trials on pregnant patients could be a big deal. So sometimes we just don't have the data, but this is kind of the data that we have so far. So these things for you to think about whenever you talking to patients about continuing their drug therapy during pregnancy. So talking about extraintestinal manifestations, so a lot of your patients, about half of patients in IBD would have extraintestinal manifestations. Arthralgias is the most common. So we know that therapies that heal the mucosa from, mesalamine to like biologics should hopefully improve some of the extraintestinal manifestations, that ones particularly that parallel the disease. So when you're studying for your boards and you see more patients, you'll learn which manifestation parallel your disease and which ones do not. They have to do their own thing. And so the boards kind of love that. So this is kind of like summarizing which one parallel your disease and which ones do not, and which ones will need like extra treatment or a specific treatment for that extraintestinal manifestation. And this table kind of summarizes, hopefully, maybe which drugs to think about if your patients have like arthritis versus which drug you would think about if your patient also have uveitis, what about if they have erythema nodosum, which drugs I should probably try. So that kind of like hopefully like keep you kind of thinking about it whenever you're reaching for which drug to pick, is thinking about, well, what else am I treating other than their Crohn's or their UC? So whenever you're picking that first line therapy, remember you want to think about efficacy. How good is this drug for the disease that I'm dealing with? How long is it going to take? Is it safe? Does my patient want to think about getting pregnant? Can they inject themselves? Can they come to the infusion clinic? Is my disease like really severe? Do I reach for something like infliximab or Vito? Is it UC versus Crohn's disease? And which drug do I think about here? And then this is kind of just another summary of which drugs will work better, like for post-operative Crohn's disease. Maybe reach for infliximab. Maybe reach for Vito. Probably maybe not tofa. Just a good table there. And then other considerations to think about, again, it's super complicated, right? You have to think about a lot of things. Is it a complicated disease like Crohn's disease? Is there perianal disease? Is it penetrating? Is it structuring disease? Are there a lot of multiple other extraintestinal manifestation I have to think about? Maybe I should, reach for infliximab or adalimumab. And sometimes you think you have the best, the really good drug. You're like, this is going to be perfect, and the patient doesn't respond. And that's why it makes IBD challenging, but at the same time really makes you think, because then you're like, okay, well, which mechanism of action did I try, and which one should I go for after? Should I do combination therapy? And then have, other things to think about. My patient had history of cancer in the past. They're older, so maybe I should, reach for maybe Vito or Rinvoq. So this is kind of like my kind of thought process. Like if I really have like severe UC, like infliximab is good, and maybe I'll try to maybe like Rinvoq. If they have a fistulizing disease and it's like really difficult to treat, I'd try a combination like an immunomodulator with infliximab. If it's a non-fistulizing disease, maybe a TNF, maybe Vito, maybe Rinvoq. Psoriasis, Skyrizi or UST will work. If they have arthritis, I usually reach for infliximab personally. If they're older and they have history of malignancy, my go-to right now is Vito or Rinvoq. If they have uveitis or biderma with their IBD, I usually try maybe TNF. And if they're mild to moderate and they failed like mesalamine, I usually try to probably pick Rinvoq. I haven't tried the other two, but I usually pick Rinvoq so far. All right, so remember, big thing with IBD is you have to try to treat the whole patient. There's a lot of things to think about in terms of the disease, in terms of your patient. Remember to always exclude confounding factors, like is the patient maybe have an infection, maybe they have C. diff or CMV, rather than they're just like not responding to my therapy. Remember to try to do appropriate therapy, so try to pick the right drug for the right patient, and try to always assess the response. So, and always the big target for you is mucosal healing, so always strive for that. All right, that was all the slides. Thank you.